Don't you want to try and disprove your method in order to prove how strong it is?
So at this point in my career, no.
A SPECT scan takes 3D images of the brain, looking at blood flow and activity. Dr. Amen says the images can be a powerful tool to diagnose underlying problems.
I have more experience in this than anybody probably in the history of the world.
Do you not feel that it's an issue that there is no randomized control data?
I went and got a brain scan by this guy called Daniel Amen.
How do you know what is actually going on in that person's brain without looking?
By asking them questions, by doing
That's
validated
complete crap, Mike. It's complete crap.
Today's guest is Dr. Daniel Amen, a physician with double board certifications in psychiatry and child and adolescent psychiatry. He's a multiple New York Times bestselling author and has just published a new book called Change Your Brain, Change Your Pain. He is also the founder of Amen Clinics, a nationwide network of offices that rely heavily on SPECT scans, a unique functional imaging approach that Dr. Amen claims is capable of identifying psychiatric diagnoses within the brain, which allows him to create better treatment plans for his patients, which often include supplements he sells through his other company, BrainMD. As you'll hear him say, he's reviewed hundreds of thousands of these scans, which he's used to improve the lives of countless patients over his decades-long career. Given that major health organizations have come out against using SPECT in this way, I needed to ask what research he was using to guide his protocols. Because if you're gonna go against the APA, the AAN, you have to have some pretty compelling data, right? Let's talk historically how you got into this space, because I don't see a lot of folks, at least on the internet, talking about neurology, psychiatry, and how these two fields come together. Is this a unique field? I'm not certainly exposed to it as a primary care doctor, so I'm curious how you found your interest in that.
So when I was 18, Vietnam was going on, and I became an infantry medic, and that's where my love of medicine was born. But about a year into it, I realized I didn't like being shot at, so I got retrained as an X-ray technician. And that was pivotal for me because our professors used to say, how do you know unless you look? Mm-hmm. And then 1979, I'm a second-year medical student. Someone I love tries to herself, and I took her to see a wonderful psychiatrist. And I came to realize if he helped her, which he did, it wouldn't just help her, that it would help me. It would help her children. It would help her grandchildren, as they would be shaped by someone who was happier and more stable. So 46 years ago, I fell in love with psychiatry. I've loved it every day since. The only medical specialty that never looks at the organ it treats. Think about that.
Is that true?
That is absolutely true, that they still make diagnoses based on symptom clusters, the DSM, that has no neuroscience in it. They make diagnoses based on symptom clusters with no biological data, exactly like they did with Abraham Lincoln in 1841. So think about that.
Yeah,
right?
Why is that?
Because it's the paradigm that feeds the pharmaceutical industry. It doesn't feed outcomes because our outcomes are not better than they were in the 1950s, the year I was born.
How are you, where is
the,
like in terms of more people being sick or people not being helped?
More people being sick. And if you are sick, your ability to get better, right? Imipramine was released in the 1950s. We don't have antidepressants that are more effective. Now, we have ones with fewer side effects, but not more efficacy. Thorazine was released in the 1950s. Ritalin was released in the 1950s. Why? And so I asked the question, and when I was growing up, my dad had two favorite phrases. Bullshit was his first one. Like everything was bullshit. And no, bullshit, no. And so when I'm like, well, why aren't we looking? They go, well, it's the future. And I'm like, bullshit, no, we should do it now. There's technology now. And in 1991, I went to a lecture on the imaging study we do at Amen Clinics. I have 11 clinics around the country. It's called Brain SPECT Imaging. SPECT is a nuclear medicine study that looks at blood flow and activity. It looks at how your brain works. And
how's that different from functional MRI?
So functional MRI is harder. You have to catch that difference in brain activity. SPECT actually gives you a look at how the brain works over time. So it looks at about a 2-minute snapshot of brain activity, but it happens to be very consistent over your lifetime, unless you do things to change your brain. And so now we have almost 300,000 scans we've done on people from 155 countries. And literally, it changed everything in my life from the time I go to bed, because what I realize, most psychiatric illnesses are not mental health issues, they're brain health issues. Get your brain healthy and your mind will follow. And so when you...
How is that? What's the difference between mental versus
So if you
brain?
think of it as mental health, so number one, no one wants to be called mental, right? Because it shames you. It's stigmatizing and it's sort of about you. When it's brain health, well, everybody wants it. And if it's mental health, okay, diagnoses, symptom clusters, let's do this medicine or that medicine, right? As a family doctor, you treat more psychiatric patients than most psychiatrists. It's like almost half of the patients that come see you are stressed, they're not sleeping, they're anxious or depressed.
Especially my pain patients.
And the tools you have in a limited office visit is medicine. And yeah, it's like, okay, symptom clusters, medicine or therapy, and then I'll see you back. Where if it's brain health, you have to lose weight, because I published 3 studies on 33,000 people that show as your weight goes up, the size and function of your brain goes down. It should scare the fat off anyone. You have to get your diabetes under control. You need to go to bed. Alcohol is not a health food, and marijuana is not innocuous. So what you begin every patient, this is not true if it's sort of a mental health issue. If it's a brain health issue, you have to ask yourself, whatever you're doing today, is it good or bad for your brain? So it's a completely different paradigm and a completely different discussion.
I'm trying to think of how I go about seeing a patient that perhaps has a psychiatric concern, or maybe even doesn't and doesn't realize that they have a psychiatric situation going on. Obviously doing the symptom clusters, the checklists, the PHQ-9s, all of these GAD-7s that they fill out. And then you're right, it's either therapy or medication, a combination of medication, and then see you later, especially with our broken healthcare system. It's near impossible for anyone with not the greatest insurance or paying cash to even get therapy, let alone quality therapy. So I see that happening. But the idea of weight loss and getting their diabetes under control, to me as a family medicine doctor, especially as a DO who thinks very holistically, that is almost always included in my mental health portfolio. Is it just because I'm automatically thinking about mental health as brain health?
No, it's because you're rare. That very few family doctors go, you're depressed, could be from the inflammation you're creating from the extra weight and the ultra-processed food. It's, you're depressed, that means you need an SSRI. And, you know, the serotonin hypothesis for depression, it's not well supported.
Oh, for sure.
And
we've gone back and forth on, is it receptor modulation? Is it
But
this?
see,
Is it that?
I don't think depression should be an illness. I think depression is like chest pain. Nobody gets a diagnosis of chest pain. Why?
That's in my ICD-10 diagnosis.
Well, yes, but nobody gets, no thoughtful cardiologist goes, that's your problem. You have chest pain. It's a symptom. Depression is a symptom that has many different causes. And there's certain brain patterns that respond to SSRIs, especially if you have increased activity in an area of the brain called the subgenual cingulate gyrus. So yes, SSRIs work for that. But what if you have low activity in that part of the brain? SSRIs can make you violent or suicidal. And there are black box warnings on SSRIs. There are black box warnings on every psychiatric drug, because depression can happen from a head injury. like you had a whiplash injury, so you never even really thought you had a head injury. It could come from toxic exposure, like lead or heavy metal or mold. It could come because your brain works too hard, from Lyme disease, or not hard enough. And so the standard, your PHQ-9 is elevated. So here's an antidepressant plus therapy, or one or the other. And I'm like, well, why are you depressed? And that's not the question people really ask.
I'm curious about the chicken or the egg scenario with the weight and poor diet. I have patients that I believe that there's a component of their weight, their diet, their choices in life are impacting their feelings, leading to the symptom of depression. Because technically, I don't diagnose someone with depression. I diagnose them with major depressive disorder or dysthymia, some kind of more DSM appropriate diagnosis. So how do I know, is this a symptom or a sign of them having major depressive disorder leading to unhealthy eating? Or is it the other way around, that the unhealthy eating is causing those symptoms?
Well, I would think we should look at their brain before we go about changing it. And then I think a really good detailed history will give you a good idea. Now, if you can't get a scan, look at their ACE score. And I don't know if you do that
Adverse
routinely.
experiences.
But I published a study last year on 7,500 patients looking at adverse childhood experiences. So on a scale of 0 to 10, how many bad things happened to you as a child? And so if you have increased trauma, you have increased activity in your limbic or emotional brain, or when we talk about the pain book, in the suffering pathway of the brain. So you're more likely to eat simple carbohydrate foods because that raises serotonin.
Oh, yeah.
If you can get an insulin response, then it raises tryptophan in the brain and serotonin, and you feel happy. Now, you don't feel happy really. You feel happy
temporary
for the, you
boost,
feel
yeah.
happy for the
Until
moment.
the next
right. I want my patients to feel good now and later,
Right.
versus now but
Without
not
the
later.
negative effects of overeating.
Without the negative effects.
So in these scenarios, when let's say they have elevated ACE scores and as a result they're having worse lifestyle changes, how does getting the imaging improve that level of treatment? Because let's say I have a patient who has a high ACE score, who's consuming a lot of foods. We would be discussing the consumption of those foods as part of their metabolic workup, knowing that there's an added benefit to their mental health state, but it would be primarily focused from a metabolic standpoint. So what does the imaging add to it?
So many different things. The first thing it adds is compliance, because people see their brain, they begin to have a relationship with their brain, and they want it to be better.
Okay.
So it's the reason
It's showing them a bad EKG when they're having chest pain.
or high liver function tests,
Right.
and they're drinking
For
too
fatty
much,
liver, sure.
right? In 66% of the time, if you show them an abnormal lab test, they want to do something to make it better. But now, so when I did my first scan, it was 1991, I scanned my mom the week before, and her brain was beautiful, and mine wasn't. And I developed a concept I call brain envy. Freud was wrong. Penis envy is not the cause of anybody's problem. Brain envy, right? That's the organ where size really does matter. You want a healthier brain. And I just wanted my brain to be better. So that leads to a cascades of decisions. If you go, is this good for my brain or bad for it? So that's the first thing that I fell in love with imaging, compliance, and it decreases stigma. And it gives you as a physician targets to go after. Is the brain overactive? So I need to calm it down. And from a medicine standpoint, SSRIs or anticonvulsant medications calm it down. But if it's low in activity to start and you calm it down, you've just disinhibited that person, which can be
Well, there's some
problematic.
activating antidepressants. Wellbutrin is a common option.
But how would you know where to start?
Well, based on symptoms and what they're
Based on
experiencing.
symptoms. But what other specialty in medicine acts without imaging?
I don't know if that's a valuable question, though, because not every specialty is going to have equivalent need for imaging. For example, for me to make a diagnosis of a UTI, I don't need any imaging or any
But
lab
you need
tests.
a lab test.
You don't. It's a clinical diagnosis. So if someone has symptoms, dysuria, suprapubic pain on a physical exam, perhaps CVA tenderness, I can make that diagnosis. I technically don't need the tests. There are in moments where it's valuable to get a test if you're concerned about a kidney stone, if you're worried about someone who has a high risk UTI, like someone in pregnancy, so you need to get a urine culture to confirm sensitivity. So there's a lot of these specifics, but I'm interested in your reasoning, the compliance, the stigma. I think those are
And
really
the roadmap.
and the roadmap of treating to some outcome. So now I'm curious about the compliance portion of that. Not every patient's going to have access to imaging, just simply because of the nature of our healthcare system. It sucks. A lot of people can't afford even basic medications. The other day, I prescribed clindamycin for a patient, and their insurance denied it because I sent capsules, not tablets. Just some ridiculous notion, which is typical for our system. So when I think about our system and who I treat, especially in a community health center, I think about those people who can get imaging, and then the worry that it instills in them as if I'm treating them badly because they will view our podcast or they'll hear a news story about the need for imaging and that we're functioning basically as we're blind. And then those people feel like they can't get care from me or their psychiatrist. Do you worry about that outcome?
So from the beginning of the time, I've done imaging, and that's why I write. That's why online you can take our brain health assessment, know what, based on our work, what type of brain you have. You have a balanced brain, a spontaneous brain, that's my ADD group, a persistent brain, my OCD group, sensitive or cautious brain. So these symptoms tend to go with these patterns. So I think people can benefit from my work for free, right? They can go to the library and get Change Your Brain, Change Your Pain, or Change Your Brain, Change Your Life, or any of the 40 books I've written, or they can listen to our podcast. And so there's so many people, everywhere I go, people go, your work changed my life. And they never got a scan. But
So the scan isn't necessary?
I would argue psychiatry is broken, and we need to be viewed as a real medical specialty with imaging, because if you don't look, you don't know. So, for example, one of the big lessons is mild traumatic brain injury is a major cause of psychiatric problems, and nobody knows it because psychiatrists don't look at the brain, or family doctors don't look at the brain in this person who's having problems with domestic violence, or this person who's been incarcerated 3 times, or this person that is homeless. And no one's thinking, did that car accident damage their brain?
So are psychiatrists who are not using brain imaging, by functioning without looking, are they doing a disservice to their patients?
I think they're flying blind, and they're missing so much that could be gotten from imaging. Is your brain hurt? Is it toxic? Is it overactive? Is it underactive? Like, I'm a psychiatrist. Why do I care about Lyme disease? Because it's a major cause of psychiatric problems. Yeah, I think as a profession, we can do so much better.
And you mentioned,
And that's why in medical school, psychiatry is sort of looked down on. It's like, really? That's
well, is it looked down
soft.
upon because it's the lowest reimbursed field out of all of the specialties?
No, I don't think so. I think it's
I mean,
looked down
family
on.
medicine, pediatrics, and psychiatry are the lowest ranked fields, and they're the
And
lowest
those were
paying
the 3
fields.
I was interested in when I was a medical student, because it wasn't about the money. It was about where I could do the most good.
Sure. Well, we definitely need the most help in those specialties. Because I think a good primary care system is the backbone. I don't know if you agree.
Absolutely.
To a good healthcare system.
No, you should have a wonderful family medicine doctor, but most people use the emergency room
or urgent cares, which there's no continuity, and it's
right. Just the relationship.
Yeah.
And I trained in the early 80s before managed care took over medicine, and I'm so grateful that I did, because in the early 90s, psychiatrists became the prescriber, and they just ruined the profession. Like for me, I was taught to do family therapy and group therapy and individual therapy. And medicine was just sort of a part of what I did. And I wouldn't be happy if I was the prescriber.
Probably in the same way that I can relate to that in being a family medicine doctor, there are a subset of family doctors who have trained to be referrologists. You have high blood pressure? Here's a cardiology referral. Oh, you have a UTI? Here's a urology referral. You don't need to do that. I constantly have to remind my residents that 90% of all medical ailments can be handled by a primary care doctor. And there are subsets that are complex, that require specialist intervention, procedures. We don't do colonoscopies as a simple one, surgeries. So there's a lot we can handle. And I think there needs to be improvement across all these fields, especially in the area of education. So much how you're talking about the prescriber, I'm talking about the referrer in that regard.
I love that. It's the first time I heard that term. Yeah. And it's like, no, that's not why we went to medical school.
Correct.
Right?
And
we had to take all of those rotations.
Exactly. And we forget them because it's easy to just refer. It also shifts the legal concern. Oh, well, I sent you to the cardiologist. They made the decision. It takes the decision-making pressure off me. So I don't like that in terms of practicing medicine that way. So I agree with you in that regard. You mentioned some of these brain classifications that you do to see if someone has a ADHD type brain. We have all of these validated PHQ-9s, GAD-7s, Vanderbilt, MCHATs. These are questionnaires we give to patients. Sometimes we give them to parents, to teachers. Do you not like those ways that we make
give
diagnosis?
Them to our patients, but depression is clearly not one thing. Anxiety disorders are clearly not one thing. Now, you get a high GAD-7. So what do you do with that? Do you give them a benzo that's addictive, that increases their risk of dementia?
I mean, that's out of standard care.
You don't,
but that's out of standard care.
27% of all doctor visits, someone's getting a benzo. This is
poor medical
insanity.
Care. But that's not what the agencies recommend, right? If we were to go on to the APA or any of these organizations, they wouldn't say that that's standard.
I mean, hopefully you teach them diaphragmatic breathing. You give them things like theanine, maybe from a medicine standpoint, propranolol. But that's not.
I mean, now we're even introducing allergy medication for people who have anxiety. So
yeah, the antihistamines that also increase the risk of dementia.
Yeah, for sure. Overuse a lot of it. But I mean, every medication has some sort of trade-off.
Right, but teaching someone not to believe every stupid thing they think and teaching them diaphragmatic breathing, no side effects, no increased risk of dementia, and probably decrease the risk.
It sounds like you're a fan of therapy, of cognitive behavioral therapy. Are you?
Absolutely.
Okay.
And I think family doctors, if they just learn some of the basic principles, right? I talk about killing the ants, the automatic negative thoughts that steal your happiness. Okay. Whenever you feel sad, mad, nervous, or out of control, write down what you're thinking and just ask yourself whether or not it's true. And in the book, part of the doom loop is an invasion of ants, these automatic negative thoughts. And there's nowhere in school where we teach kids not to believe every stupid thing they think. I was 28 years old in my psychiatric residency when one of our professors said, you have to teach your patients not to believe every stupid thing they think. And I'm like, but I believe every stupid thing I think.
Revolutionary idea.
Right? It's like, but that's such an important concept. if patients came in knowing how to manage their minds, they're going to have a lot less back pain. They're going to have a lot less neck pain because negative thinking goes to more tension, which then leads to more pain.
Yeah, we talk about that a lot on the channel. Are you familiar with Dr. Sarno's work?
Love Dr. Sarno's work.
Same.
I talk about
Oh,
him
really?
in the
Okay.
new book because what he basically says is chronic pain is repressed rage. But he doesn't do a great job of helping people get rid of the rage. And so in the book, Pollyanna actually meets Hannibal Lecter because you have to have a mechanism to get in touch and express the rage in an appropriate way while you're directing your mind to what's right rather than what's wrong.
Yeah, I think he was ahead of his time to some degree, and people will point out flaws of, he had this theory of increased muscle spasms due to decreased blood flow to a specific area. And when that was somewhat disproven or questionable, they threw out all his theories. And I feel like as someone who's practiced medicine for over a decade, I've seen his theories play out, not just from I see this happening with my patient, but direct intervention in handling anxiety, stress, childhood traumas, just discussion of those issues leading to elbow pain going away. So I believe that there's definitely a variable there. Sometimes it's hard to get patients on board though. I've had patients get very offended at me when I say, hey, what's going on in your life emotionally? What was your upbringing like? And they'll say, why the hell are you asking me this? And I explain, they say, well, you're one of these asshole doctors that just wants to blame it on me. And I say, no, quite the opposite. I'm explaining that you have an internal regulator that basically dials up volume when you're stressed, as it's supposed to, as part of its survival mechanism, and then down regulates it when they're having a good time. Because you just told me that your pain is only there when you're working, but not when you're having fun with your friends. But it's still sometimes hard to get buy-in. What's your strategy on getting that buy-in?
People say, oh, well, you think it's all in my head. Well, absolutely. But it's in your brain, which is in your head. That if you've had pain for more than a couple of weeks, that now has a signature in your brain. And if we don't get your brain healthy, the pain's going to stick around. And one of the reasons I wrote Change Your Brain, Change Your Pain, I'm 71, is I just got tired of being in pain all the time. It was my back, it was my knee, it was my neck, it was my hip. And I'm like, what is going on? So read Sarno's work, started looking at the scans of our patients in chronic pain. And I'm like, oh, pain gets stuck in your brain. And the one study that just completely blew my mind was 80% of people my age have abnormal backs who have no pain.
Oh yeah, that's
who have
the classic
no
example.
pain.
Why try and talk patients out of MRIs for their spines just because?
And what I have found that when people go get them after I teach them this, their abnormal neck doesn't freak them out, so they automatically go get surgery. They go, oh, 70% of people my age have abnormal necks who have no pain. So it means your body can figure out how to heal around the arthritis in your neck or the crushed disc in your neck. And that's so freeing to me. And it's like, if I calm my brain down, my pain's going to be less. And now I'm in no pain at all, which I dearly love, because it doesn't freak me out if I wake up and my neck is sore.
Sure. What do you say to patients? Because I've had this end up even with the patient filing a complaint against me. I have a whole video on the channel about it, where I was trying to discourage the patient from getting an MRI for low back pain that I believe not to be from a spinal cause based on my physical exam, the history of present illness. And I felt like there was an emotional component. I introduced it. I asked how they feel about that. They said, I still want the MRI. I said, I'm happy to order the MRI, but I'm just explaining that if we find something on this MRI, we're likely to end up chasing it when it's not the cause. And she didn't like that answer. So I'm curious how you go about avoiding unnecessary imaging in those cases.
Well, I'm a huge fan of informed consent. This is, do we agree on what the problem is? So back pain. Okay, you have back pain. Here are the things we can do. And here are the pros and cons of those things. What do you want to do? You decide. And if I've done a good job of connecting with them, generally they'll choose what my recommendation is, but not always. And as long as it's not irrational, I feel like I work for my patients. I don't work for the insurance companies. I work for my patients. And generally that works out for me. And I think works out for my patient, because if they do something that, I don't think I would have done it, and it doesn't work, they trust me because they feel like I'm their partner.
So you're saying perhaps I didn't form a good doctor-patient alliance with this patient.
So alliance is so important. I mean, I don't know, because I wasn't there, and you probably were as kind and empathetic and listening as you could have been. One of the things I learned is, and I guess I'm free associating, you have to ask patients 10 times whether or not they've ever had a brain injury. It's shocking to me. So I start imaging. I'm like, oh, have you ever had a brain injury? You can see the damage to the left front and to their anterior temporal poles. It's a sign of traumatic brain injury. And they go, no. I'm like, well, are you sure? Have you ever fallen out of a tree, fell off a fence, dove into a shallow pool, had a concussion playing sports, been in a car accident? No, 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 no. Oh, it's always no, no, no. Oh, I fell out of a second-story window when I was 7. Do you think that counts? Or I fell out of a moving vehicle going 30 miles an hour. Do you think that counts? And I just think it's one of the major causes of psychiatric problems.
So when you have a patient that you come across with a history of falling out of a window when they're 7, how do you alter your approach to treating that patient?
Well, we go repair the brain injury, right? If you don't do that, then they're going to be living with chronic whatever, depression, irritability.
Not surgically.
No, put them in a hyperbaric chamber. So I did the big NFL study when the NFL was sort of lying. It had a problem with traumatic brain injury in football, right? Everybody knows CTE. And they have the wrong thoughts on CTE, which we could talk about. But in 1999, Brent Boyd, who was offensive guard for the Minnesota Vikings, came to see me. Clearly had traumatic brain injury on scans. And by then, I'd already been scanning people for 8 years. He filed a workers' comp claim. The NFL said he was faking and called me a quack and just completely dismissed it. Well, in 2007, Anthony Davis, the Hall of Fame running back from USC, came to see me. His brain at 54 looked like he was 94. But 5 months later, he's dramatically better. And we partnered with the NFL Players Association in Los Angeles, published the first largest study on 100 active and retired NFL players, high levels of damage. But 80% of our players got better. We put them on a really good multiple vitamin, high dose, high quality fish oil, and a brain supplement that works in 6 different ways. 80% of our players got better. Their imaging was better. And for those that didn't, we put them in a hyperbaric chamber, and that improved our outcomes even more. So I'm really excited. So the idea is, okay, boxing, football, soccer, rugby, horseback riding, they're brain damaging sports. But you can get better if you put the brain in a healing environment. So we specifically target repairing those parts of the brain. And I don't know, a supplement company, so I'm a huge fan. But I'm also a huge fan of hyperbaric oxygen therapy. Published a study on soldiers who had blast injuries, showed significant improvement after the first session, and then much more after the 40th session.
You mentioned you're the owner of the supplement company. How do you protect yourself from the conflict of interest that can happen in scenarios like that?
I write about the research. I love what we do. I'm so proud of what we do. So, for example, we make Happy Saffron, 28 randomized controlled trials, 30 milligrams of saffron, equally effective to antidepressants. So I think my job is just, one, tell people I own a supplement company, so
Clear disclosure.
people know it, and then write about the science behind the ingredients we have. And so I always say no brand violations, that we only want high quality things that have efficacy. And I love that. So it's not a secret, right? Brain MD by Dr. Daniel Amen.
Yeah.
And people go, oh, but he makes money. Well, I'm like, no margin, no mission. It's like, that's not illegal, right? All doctors get paid for what they do. But I love it. And after we made Happy Saffron with saffron, zinc, and curcumins, there's a brand new meta-analysis on 192 studies on 17,000 patients. Saffron effective as an antidepressant. But when you add zinc and curcumin, now this is true if you add it to saffron or Lexapro, if you add zinc and curcumins, they actually work much better. And so I was very happy that I figured that out before.
For the conflict of interest portion, people always, I get this sent to me, you're a pharma shill, you prescribe medications, therefore whatever you're recommending is not good. And we hear even Secretary Kennedy of HHS now say similar things. Basically, people badmouth pharma because they're for profit. Do you think that's unfair?
Absolutely. I mean, there are other reasons to badmouth pharma.
Like what?
But we absolutely need pharmaceuticals. And for the right brain, they're incredibly effective. And if the companies didn't make money, they wouldn't be in business.
Yeah.
And I'm a huge fan of medicine and prescribe them when I think it's appropriate. And I'm a huge fan of supplements. And why? Why did I get interested in supplements? When I started imaging, I realized some of the medications I was prescribing were not good for the brain. And you remember in medical school, they go first do no harm and use the least toxic, most effective treatment. And so if omega-3 fatty acids head to head against Prozac were more effective in a study from New Zealand, well, why wouldn't I start with that?
Well, it depends how
saffron?
severe the person's symptoms are.
Well,
if
but
someone
that's
is having
the-
ideation, you don't want to start with omega-3s.
Well, nothing works by itself, right? If you look at the studies, there's not much that works by itself for the most severely depressed people. And I would argue it's because often it's not only the depression, but it's the head injury that's complicating it, or it's the infection. Yeah.
You mentioned
but
that
that's why I got interested in it.
yeah, you mentioned there are some reasons to be critical of pharma. What are those?
Well, I think that they market them nonstop. And so they almost creating the market for it.
How is that different than your supplement line?
That's a good question. Supplement companies like mine don't have nearly the money that pharma has. And so...
Well, the Global Wellness Institute estimates that the wellness industry is a $2 trillion a year industry in the United States. And big pharma is $700 billion.
That would shock me, right? Because I own a supplement company, knowing our budget as opposed to Eli Lilly's budget. It's like we're not even talking the same thing, or even the very large supplement companies. So I just don't know the
Yeah, well, let's take the
statistics.
numbers out of it because that needs to be fact checked. But let's say for those who want to advertise a supplement, Like if I want to start my own supplement company, we have 14 million subscribers, very healthy YouTube channel, very active audience. If I wanted to start a supplement company, it wouldn't take much. I have to get someone to give me the ingredients, to create the label, send it out. But pharma has to go through trials. The FDA has to approve it. They have to spend a lot of money. Don't you think it's easier to create a supplement than it is to create a pharmaceutical?
Yeah, no, I think absolutely you're correct. And there are a lot of bad actors in the supplement world. So
like who?
Finding somebody you trust is important.
What's a bad actor in the supplement space?
Well, somebody who doesn't test the ingredients, someone who you don't feel confident what it says on the label is actually in the bottle.
So how does an average person to decide that?
I think they have to find brands they trust. Consumer Reports does analysis, does independent testing. There are other companies that do that.
Yeah, like Consumer Labs, Consumer Reports have done a lot of these trials, and they go to the local pharmacies. They take things that are top selling, and they find 70% of them don't have accurate ingredient lists. Shouldn't that worry people about the supplement industry?
It should. And I think they should be cautious, careful.
And again, I'm trying to figure out what practical advice to give them there. So how can they be cautious, careful? They can't test what's in there, which is why I think the FDA
they can go
tests.
to a place like Consumer Labs and go, which are companies that are reliable, consistent. I think that's my best advice. But before I had my supplement company, I would do that and recommend certain brands for my patients.
Mm-hmm. And if, let's say, so the FDA currently doesn't look at supplements, right? But they look at the pharma industry to make sure everything is standardized, validated, efficacy rates are tested. Even if pharma markets a medication for a use that it wasn't initially approved for, they get in trouble, right? They get huge fines.
The FTC, the Federal Trade Commission, if you're marketing a supplement inappropriately, they'll send you a letter, they'll fine you, they'll put you out of business.
Yeah, you have to be somewhat careful, because I looked into starting a supplement line. If you don't say that something clearly cures something, and you just say balanced brain or healthy energy levels, and you don't clearly say that it does that, you can get by making all sorts of claims. And historically, people have destroyed their livers with some of these supplements, the hydroxycut scandal of years ago. So there's all these it's like kind of the Wild West out there when it comes to the supplement game.
But I read one study. Your chances of dying from a supplement are like 60,000 times less than dying from a medicine. Now, it doesn't mean that you shouldn't be thoughtful and careful on what you put in your body. You absolutely should be. But when we look at pharma and the level of death from pharmaceuticals, it's not even in the same league with supplements.
Mm-hmm. So death is the way you judge the safety of these medications?
Well, it'd be one way.
Well, sure, but the idea that 70% of them don't have the thing in them, that's pretty problematic too. Imagine the pharmaceutical industry turned out that when we tested their medications, they didn't have what was in there. Their insulin was only present 70% of the time. That would be a big deal.
You know, I can only speak for BrainMD, and
Sure.
I'm very proud of what we do.
Do you think the FDA should be out there randomly sampling and testing to make sure that these supplement companies have what's written on the label?
I think it's a good idea to police whatever people put in their bodies.
Mm-hmm. Yeah, I'm always for that, just because right now it's, again, such a Wild West. Even Consumer Reports published recently a study of heavy metals inside protein powders and how people can be inadvertently trying to be healthy, but perhaps getting, especially if they're taking mega doses, some of these bodybuilders, scoop, 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 scoop. And before you know it, you can get a serious problem developing there. And some of the brands are very legitimate, very popular brands that you see selling quite well. So I'm always trying to figure out what's a safe recommendation that I can give universally to my patients. I'm curious, we never kind of settled on our question about the compliance issue. That you mentioned that getting these imaging tests is valuable for compliance. And I was talking about how it could potentially scare people away from seeking healthcare, from a mental health care specifically, from a provider who doesn't do imaging. Do you have any fear that you might be discouraging patients from getting good quality medical care or mental health care just because they're not doing imaging?
Well, I guess, the question I have is, do you really get good quality brain health, mental health care if you have no idea what's going on?
Well, that's a good question. Yeah, maybe you can answer that.
You're treating. I don't think so. I mean,
Really?
I wanted to write a book once called Flying Blind and the Rating of the American Mind.
Wow.
And,
Dark.
And I'm sort of sad I didn't write it. I actually had a book deal for that book. And I'm like, it's just too negative. But what is happening in American society today where 57% of teenage girls report being persistently sad, or that it has increased significantly in the young since the year 2000? That with all this sadness, the use of antidepressant medication has skyrocketed. 2021, there were 337 million prescriptions written for antidepressants, and we're not teaching people how to love and care for their brains or manage their minds. And I think if we imaged, that people would care about their brain a lot more. They would just eat better, think better, and do a better job of taking care of themselves. So I think we're in, I call it a whole 4 crisis. We haven't talked about this. Don't hate me. God, it's so frustrating. I'm working with the White House on a national brain health revolution initiative, specifically with the White House Faith Office, because they believe that brain and mental health are sacred human rights. And I have people that just love me and support my work there. And as I explain it, we're in this whole 4 crisis. We're in a physical health crisis. I think you and I would agree with that.
Big time.
With
Chronic health conditions,
75%
all-time high
of people overweight or obese, 50% diabetic or pre-diabetic. 90% of our healthcare dollars are spent on chronic preventable illnesses. We have these epidemics of anxiety, depression, autism, ADHD, addiction before the pandemic, and then everything got worse. Loneliness, 58%. So biological, psychological, social, spiritual, where 58% of young people report a lack of meaning and purpose. But I believe the answer to these epidemics is not to see them as separate disorders, but as different expressions of the same unhealthy lifestyle that have exactly the same cure, which is getting your brain, mind, relationships, and spirit healthy all at the same time.
Yeah, you're looking at it more holistically.
Right. I did a program with Pastor Rick Warren called the Daniel Plan. It actually came out of a prayer. I went to my church. I just finished writing Change Your Brain, Change Your Body. It's 2010. Went to my church on a Sunday morning. I was so happy and walked by hundreds of donuts for sale for charity, and it just pissed me off. I'm just like, I'm going to church to get my soul fed. These people are trying to kill me. And I prayed God would use me to change the culture of food at church. And 2 weeks later, Rick Warren, who is our generation's best-selling author, he wrote The Purpose-Driven Life, sold 50 million copies. He called me up. He said, I'm fat. My church is fat. Will you help me? We created this program called the Daniel Plan that ended up being done in thousands of churches around the world. Mm-hmm. And how do you get people healthy? You get them healthy where they live, whether in their community, in their churches, in their businesses, in their schools. And that's part of this sort of national brain health revolution.
Yeah, this mental health crisis that we're facing, we have, as you said, teenage girls experiencing high level of sadness. The amount of SSRI and antidepressant prescriptions are going up and up. You think this is partially due, or maybe majority due, to the fact that psychiatrists are rigging their brains?
I think that as a specialty, we have gone to be the prescriber rather than the healer. That antidepressants don't cure anything. They suppress symptoms. I think.
Do they say that it
obviously
cures
it's
it?
not psychiatry's fault.
But I've never heard a psychiatrist say that antidepressants cure depression.
You don't hear that.
Yeah.
That it cures anything.
Right.
Right. I heard once John Paul DeJoria speak. He founded Paul Mitchell, the famous shampoo company. He said, you never want to be in the order business. You always want to be in the reorder business. And, once you start these medications, people don't stop them.
Well, the goal is not to use them indefinitely. I think the correct indication is to create a bridge to get people over their life.
And how many
event.
of your patients, once you start them, stop them?
Almost all. I have a rule that if we're starting an antidepressant, we're creating a date that both me and the patient are comfortable with, where we're doing reevaluations, whether or not they feel that they're in a safe place to come off, given their circumstances. Because being in a community health center, I'm working with people who are disadvantaged, who are taking care of multiple children on their own, family members in prison. And as a result, sometimes they need the antidepressant. They don't have the capacity to get scans, to get a hyperbaric chamber. It's not feasible. There's the perfect model, and then there's the realistic model by which a lot of family medicine doctors have to practice by. And
we're talking about two different things. Yes, I think in this situation, but most people who start stay on them. Most people who start don't have Dr. Mike that go, we're going to start this, and then we're going to reevaluate it and work on getting you off of it. That's not been my experience.
I agree with you. I think there's a lot of reasons to that from what I've seen in the medical community. A big part of it is the consumerization of it. We blame pharma for marketing these medications when I have seen patients say that I'm not getting rid of this. This helps me and I need this and I can't function without it. And if you're not prescribing it to me, you're evil. And perhaps they are right in some instances. So I don't want to discredit what they're experiencing. But in some instances where I feel that we should be having that discussion, some patients aren't open to that.
Well, and ultimately, I think my job is informed consent, like we talked about before. But head-to-head against antidepressants, exercise is equally effective. Head-to-head
Again, there's a lot of caveats that need to be made there.
Head-to-head,
but it's
learning how not to believe every stupid thing you think is equally effective.
Sure.
And omega-3 fatty acids and saffron. And so I'm thinking, let me at least go because a lot of patients who come to see me, they don't want to take medicine. They're like, anything
which is why I think
do.
our worlds are so different. You're having this pre-selected, highly motivated, treatment-preferred specific group come to you versus I essentially function in the wild and you're working in the zoo, for lack of a better example, with domesticated animals.
I was an army psychiatrist for 7 years.
For sure.
And
but I mean in your
loved
clinic.
It.
And here, those patients aren't super excited about a specific approach.
Yeah, no, the people come see me are excited about it.
Which is a huge advantage.
But then
do you see that that's a huge advantage?
But then a lot of them, grandma's paying for them to come see us.
Sure.
And they're not super excited. And we have to get them excited. And the imaging really helps that.
Mm-hmm. Well, let's talk about the imaging because Kim Kardashian recently got some imaging done and you found some results on her. Tell me about that.
She had sleepy frontal lobes. And
what does that mean?
So SPECT is a study of relative blood flow. It looks at activity. Actually, 49% of the tracer is taken up in the mitochondria in the brain. and she had less activity in the front third of her brain, which means it's going to go with things like forethought and judgment and impulse control and focus. And she wanted to be better. She's in law school and getting ready to take her boards, and or the bar, getting ready to take the bar, and wanted to function better. And I had previously seen Kendall, who had post-COVID anxiety, and Chloe, who had a traumatic brain injury. She was in a bad car accident. And they got benefit from my work. So I saw Kim, and it just blew up because the little clip they played was her and I talking, showing her brain with lower activity in the front part, which is not good for her.
And once you find that there's this low activity, what is your recommendation in those scenarios?
Is fix it, is improve it. And so you can do it with medicine, you can do it with supplements, you could put them in a hyperbaric chamber and see if that does it. There's neurofeedback that you can do. There are also some stimulating treatments, things like TMS. So my job is to give her the options. I think we went with stimulating supplements and see how that works. And the cool thing is you can look at it again and go, well, is that working?
If you were to interview Kim and hear all these struggles that she's having taking the bar, issues with impulse control, would you have been able to come to that same diagnosis without the imaging?
Well, I would have been able to guess at it, but I wouldn't be able to know.
Well, there's a difference between guessing and asking validated questionnaires.
So I had this discussion actually with the head of the National Institute of Drug Abuse. And she goes, but the brain has language. And it's like, no, you can't see low blood flow from just talking to somebody.
Well, I could see low blood flow
insane
on patients.
Position in my mind. It's like, well, how would you really know if you didn't look? And it's like, oh, well, I can tell because you had these symptoms. It's like, no, you can't. It's like, that's a leap in logic that just isn't correct. Because that's what most psychiatrists believe now. Oh, you have 6 of these 9 symptoms. You're depressed.
Correct number.
That means your limbic brain is too active. I'm going to give you something to calm it down. Well, SSRIs wouldn't have black box warnings if it worked like that all the time. And it's just not my experience, even a little bit, is I can get 100 people that are depressed, and we're going to find 7 or 8 different patterns. In fact, I wrote a book on ADD, healing ADD, see and heal the 7 types. I'm like, it's not one thing. Why is Ritalin controversial when it can take the right kids from C's, D's, and F's to A's and B's, but make other kids suicidal, right? I mean, why is Ritalin controversial? Because it works dramatically well for some kids, and it disrupts other kids or adults.
You said that based on your questionnaire, you would still have questions that needed to be answered that you could get answered by this imaging protocol. Does your treatment then change?
79% of the time. I published a study on this where we took 107 cases, gave them to board-certified psychiatrists, took out the imaging, and we got, here's the history, here's the mental status exam, here are the answers to the questionnaires. What's the diagnosis and what would you do? And then we added imaging, and we go, in what percentage would it change? 8 times out of 10.
From their protocol, it changed their guidance?
Changed their guidance.
Why is the imaging so controversial? Like, even when you came in, you said that people hate you now. Is it because of the imaging?
Well, some people love me, but
you have a lot of people who love you.
I have a lot of people who love me. But if I'm right, and I think I am, that means 40,000 psychiatrists and actually hundreds of thousands, family medicine doctors, nurse practitioners, OBGYN doctors, internists, right? Everybody and their mother prescribes psychiatric drugs. 85% of psychiatric drugs are prescribed by non-psychiatric physicians, are flying blind. And when you say that, they don't say thank you to that. It's like, we need a new paradigm, and we need a paradigm based on imaging, because what imaging will do is completely reshape how we diagnose and treat people.
Why don't, if we're flying blind, why don't we include this imaging? Why doesn't every family medicine doctor, why does the American Psychiatric Association, American Academy of Neurology, why are they against this imaging?
Well, not everybody's against imaging. That's
well, the
really
examples
important.
that I gave.
Because,
Society for Nuclear Medicine.
Do you ever read Thomas Kuhn's book, The Structure of Scientific Revolution? It's such a good book. It was written in 1962. Because when I first started imaging, there was all-day seminars at the American Psychiatric Association on brain SPECT imaging in child and adolescent psychiatry. All-day seminars. And I went, I loved it. In 1993, I taught in it. And then they go, oh, you shouldn't use this. We're like, well, why? Remember I told you my dad, bullshit, no. I'm like, bullshit, no.
Yeah,
why? I'm a better doctor
it's a natural
because I
question,
use
then.
this.
Yeah.
And it doesn't fit the paradigm. It does not fit the DSM paradigm. As we make diagnoses based on symptom clusters with no biological data. This is the paradigm.
But if it works, why wouldn't they want it?
Okay, so Kuhn talks about 6 stages of scientific revolution. Normal science, so you're just going along doing what everybody else does. Stage 2, somebody notices there is a problem. I prescribe Prozac. Some people get better. Some people want to kill themselves. Okay, we have a problem. 3, the status quo sees there is a problem, but they make small incremental changes to protect itself and the money. And so how many versions of the DSM are there? Well, there's 6 of it. Even though it's DSM-5, there was 3 and 3R. But it's the same as DSM-3. It's really not different at all. Stage 4, somebody comes up with a new paradigm, detailed histories, imaging, natural ways to heal the brain, and an integrative or functional medicine approach. We haven't talked about that yet. Stage 5 is the most consistent of all the stages, the rejection. It's like, no, you're crazy. This is how we do it. The brain has language. You don't need imaging.
You know, in science, we're trying to always come up with the validated solution to our problems. And when I read people who are smarter than me who understand this field, like the Society of Nuclear Medicine, I don't fully understand what they're talking about. If I can't argue the nuances with them, I can't argue the nuances with you. But their statement as an organization that is set out to seek the best for their patients, perhaps imperfectly at times, say that this imaging is not validated enough to be used. And it's not that they're against imaging. They're just saying that the imaging is not validated or can be used repetitively across a diverse group of patients. So it's not that they're anti-looking at the brain. They're anti this specific method because they feel that it doesn't have enough evidence.
But you know, the Canadian Association of Nuclear Medicine wrote procedure guidelines on SPECT as if I wrote them. That SPECT is indicated for head trauma, for seizures, for dementia, for stroke, for addiction, for toxic exposure, for neuropsychiatric indications. So it really depends who you read, right?
Well, I'm reading the largest agencies that represent neurologists, psychiatrists. It's like me saying something fully against the American Academy of Family Physicians without evidence to say why I'm disagreeing with them.
Well, I have 90 studies that I have published, and I have the world's largest database. And I actually don't know what the point of us arguing about it is. I have more experience in this than anybody probably in the history of the world. And if you don't look, you don't know. And some people go, oh no, we should just continue to do what we're doing, which is a disaster in our society. And I'm like, no, I don't believe that. We need to do better. And if you don't look, you don't know.
I logically, what you're saying makes sense. And I think evolution-wise, scientifically, all these organizations will agree with you that we need to move in that space. But do we have the randomized controlled data to be able to back these things up?
Well, give me an example and I'll tell you what the research is.
Let me ask you a specific question. Is there randomized controlled data on SPECT scans and their efficacy in a specific mental health condition?
Yes.
Which one?
Well, which one do you want to talk about?
Anyone.
I mean, if you go on PubMed.gov
Well, can you name one right now?
today.
You're the leading expert. So I'm a family medicine
like
doctor. I don't know.
distinguishing, one of the most important things to do is distinguishing post-traumatic stress disorder from traumatic brain injury. Mm-hmm. And because they often present with similar symptoms, but the treatments are actually opposed to each other. PTSD, generally, you want to calm the brain down. Traumatic brain injury, you have to repair and stimulate it. I published 2 studies on 21,000 people showing we can separate these groups with high levels of accuracy. In 2016, Discover Magazine listed our research as one of the top 100 stories in science. We could also talk about Alzheimer's disease.
But that's not a randomized controlled study.
I'm sorry?
That's not a randomized controlled study.
We're talking imaging.
Yeah.
This is not a pharmaceutical intervention where we're going to do
the goal of doing the imaging is to create more customizable treatments, as you said. And if you have customizable treatments, your outcomes should be better. That's the randomized controlled study.
And our outcomes are better. We published a study
But that's not the question I'm
outcomes.
asking. Randomized controlled data is really important. Wouldn't you say to develop a causal relationship?
I'm sorry. Say this again.
Randomized controlled trials are very
good
important to
medications.
creation causal interventions. To say that this isn't just a correlation, this is a causative pathway. You need the randomized controlled data to remove outliers, to create a generalized group, to have them double blinded, to not know which one's getting intervention, which one's not. Because it's great that you're helping people. And I am so for that you're helping people. And I want more of that. Now I'm trying to think as a family medicine doctor, how can we generalize what you're doing so that I can do it too? But in order for me to do it, I need to know it works from a randomized controlled study. Why don't we have that?
So design it for me. Because you're going to randomize, you got imaging, you didn't. So automatically it's not blinded.
Well, you can get sham imaging.
Okay.
You've been doing this since 1991. So I'm trying to look at you as the expert. Like, do you not feel that it's an issue that there is no randomized controlled data? Like, you're asking me to design the trial right now.
We have data that goes, you get better and you don't. So what's the difference in depression of people who got better and those who didn't?
Where are you sourcing those patients from?
Well, from our clinics.
So all your patients are getting the SPECT. You're not separating into groups of here we're treating patients who didn't get SPECT.
Well, no, not everybody gets scanned at our clinics.
But for the research, you're pointing out, like, you have this study that shows 84% of your patients improved. But we're not comparing them against a group of people who didn't get SPECT.
No, but nobody that I know of has outcomes like that.
But do you think that's enough for me to start doing SPECT in my clinic?
I think if you started doing SPECT in your clinic, it would revolutionize your practice.
And you're saying that as someone who's passionate about it, or that there's proof of that?
No, I'm saying it as someone who has taught people around the world to do imaging, and they become passionate about it.
Yeah, so we talked about the patient selection of it all earlier, how if you have patients who are highly motivated, it can bias your outcomes. Like we do journal club in my family medicine residency. And part of it is there a bias from the patients? Is there a selection bias of who you're selecting? And when you have your clinic, people who love you, is there a chance that you could be introducing bias by only looking at the people who love you, support you, and want your treatment?
Well, I mean, we do have a more motivated group for sure. We have a group, yeah, I think it's a more motivated group for sure.
And what outcome do you think that has on the outcomes that you study?
So we actually did this study this week on compliance because we do a formal outcome study on everybody we see. I mean, I don't know if you know many clinics that do that, but the people who are very compliant get better way faster in much bigger numbers. So we ask everybody about their compliance, and compliance is just huge. I think you would agree with me.
Yeah, for sure. And it's great that you're doing the reassessment because I feel like that's huge. Missed a lot of the time.
Well, very few clinics actually focus on outcomes. And for us, it's research, but it's also quality control.
Sure.
And if you're not compliant at all, your outcomes are not very good.
That's for sure. But also mental health patients or patients who have issues with their mental health, they tend to have lower compliance, not because they're bad people or saying something negative about them. They're going through something.
No, it's because their brains aren't healthy. So, I mean, yes, they're going through something, but in large
the human
part,
experience of their
because
depression.
Their brains are not healthy. I mean, we might agree, maybe not, that if you're depressed, something's going on in the organ of how you feel, which is your brain.
Sure. And like you're such a proponent of CBT, we say depression can be a chemical imbalance. Well, CBT actually alters the chemicals in your brains, right?
Yes. That psychological treatments like EMDR or CBT impact.
DBT, whatever alphabet soup we want to put, they all help with changing the chemical composition.
Right. But you're still advocating, at least what I'm hearing, is you're still advocating for not looking before you go about changing.
Because I don't want this to feel like a gotcha, because what I'm trying to do is...
It doesn't feel like a gotcha. It feels like a good conversation.
I really want to learn from what you're doing because I want to be a better doctor, genuinely. Like my goal, why I still practice medicine is because I want to deliver the best care for my patients. And if what you're doing is great, we need to get that message out there to the world as fast as possible because otherwise people are suffering. So in order to make the generalization that everyone should get a SPECT scan before...
But that's not what I said. But if I
correct
get you to be a better doctor, just start thinking of mental health as brain health. Is this person actively working for their brain's health? You can do that in your practice. And
without
there's going to be a day when SPECT or fMRI or quantitative EEG or PET is going to be covered by insurance, and you're going to be able to use it. But what you can do today is you can go, if we improve the health of your brain, your anxiety is going to be less. And it starts with one question. I teach all of my patients, whatever you're going to do today, is it good for your brain or bad for it? Is it good for your brain or bad for it? And that will begin to spark a revolution in their life. Now, if you have somebody that's not getting better, you should advocate for them to be imaged, because to continue to fly blind is not anybody's interest.
So for my patients who have such bad major depressive disorder that they can't groom themselves, they have trouble taking a shower, the solution is asking them if what they're doing is good or bad for their brain, you think that's enough motivation to help this individual?
No, it's all of it. See, now I feel like you're twisting my
Well, I'm trying to
words to
understand.
create conflict.
Please tell me how do
It's
I
like
understand
if somebody
because you're saying the one
if
question.
somebody is that bad, you should be advocating to look at their brain, because you don't know if they're living in a mold-filled home that is damaging their brain. Right?
Why don't we
we're-
check everyone's brains?
Everybody should be asking themselves that question. Is what I'm doing today good for my brain or bad for it? But do you spend any time as a family doctor asking
About
that
mold?
question? No. Is this good for your brain or bad for it? Going through their habits or just teaching them to love
I'll be
and
honest, I
care
don't.
for.
I don't, and I'll tell you why I don't. We don't have enough time with our patients, so that's a little bit of a cop-out. But at the same time,
Yeah, because that's a really easy question. That's like
Well-
in the 7-minute visit, you can take 30 seconds to ask them that question.
You'd be surprised
But
as
you don't
a
have
family
it in
medicine.
your head yet, because we were never taught that mental
well, I was going to
health
tell you
is
why
brain
I
health.
do ask that question without asking the question, is my second point. I ask questions that don't directly ask about the brain, but ultimately point to me behaviors that they have that put their brain at risk. So I ask about smoking. I ask about alcohol. I ask about diet. I asked about intimate partner violence. I ask a PHQ-2 screening question. So while I may not be saying the question as specifically as you are, I am figuring out the mental health state of the brain. So
But not the brain health state of the brain. See, that is the distinction, that if we get anything,
what is that distinction? Because I'm having trouble understanding that.
it's not mental health, it's brain health.
What can you elaborate?
The distinction is, one is loose, mental health, that's very loose, you PHQ-9, GAD-7 stuff, or is your brain healthy? And if you want to keep your brain healthy or rescue it, you have to prevent or treat the 11 major risk factors. So I told you, so the big 3 ways I want to transform psychiatry: imaging, if you don't look, you really don't know; natural ways to heal the brain; and an integrative or functional medicine model. And that's why our model not only works to decrease depression, it helps to prevent Alzheimer's disease. And I think you prevent Alzheimer's disease by prevent or treating these 11 risk factors. And the acronym I talk about is Bright Minds. Like B is for blood flow. Low blood flow is the number 1 brain imaging predictor of Alzheimer's disease. S is sleep. And then all sorts of things in between.
So you said that when a patient is that severely depressed, they should get a SPECT scan. Is that true for all patients?
That are that severely depressed?
That they have trouble showering, getting up out of bed?
Absolutely. Because how do you know why they're that way?
Well, the issue that I believe...
No,
people,
answer the question. How do you know what is actually going on in that person's brain without looking?
By asking them questions, by doing
That's
validated
complete crap,
questioning.
Mike. It's complete crap that you know what's going on in that person's brain. You're guessing. Now, maybe it's an educated guess, but don't tell me you know, because you completely don't.
Well, here's my defense of why I feel like it's better than just a slightly educated guess. Because when you look at randomized controlled trials for people who get either therapy or antidepressants or sometimes both, we see the improvements. So while it looks on paper like a guess, we see the outcomes hold up, validated across.
I've been doing this
research.
for 45 years. You're guessing. And
But
maybe
why are
you can
you
point to
dismissing?
some studies that say, oh,
Are you saying there's no studies that show therapy, CBT has
you're
evidence-based
completely mixing lots of different concepts.
What concepts?
This patient, you don't know because you didn't look. Now, are there studies on big populations? And most of the severely depressed, like you're talking about, there's not one single thing that works for them. They need a combination of things.
I didn't say that they wouldn't. I just said that there could be a combination.
But you don't know what's causing it.
And I think imaging holds such a key here, which is why I'm trying to figure out how to get it to the masses on a level that is scalable. So I'm trying to figure out how we get there. How do we get SPECT across the APA, the AAN? How do we get everyone on board?
I think the Canadian model, I mean, it's covered by insurance in Canada. I think that is a really great model, that there's a lot of research that when you really understand it and put it together, that imaging plus clinical evaluation, we have better outcomes. And that's why they wrote the paper. I didn't write it. I'm not an author on it.
But we don't have that. I just asked you.
No, we do have imaging and head trauma, imaging and depression,
but I'm
imaging
not asking
and
for
ADD.
imaging.
You're
in order to universally recommend a treatment, you need
it's not
randomized.
A treatment, it's an assessment.
I know, the assessment leading to the treatment, which changes ultimately the treatment because it's customizable. In order to verify this, we need to be able to test it with a randomized, double-blinded, controlled study. And in 30 plus years of doing this, you're okay with not one study being done?
So I've published a lot. Like I publish on NFL players, and I published on here's the pattern for it. Here's the pattern that after treatment. I haven't done a study where, okay, everybody gets scanned, but we only use the scans in half the people and see. I think that's the study you're thinking about.
Well, let me ask it to you in a different way that takes us out of the equation. If a pharmaceutical company came out and said, we have this medication, it works, we never tested it against any other placebo, no randomized controlled data, but everyone who takes it loves it, would you buy into that pharmaceutical? Or would you say, I need to see the data?
You always have to see the data.
But where is the data with SPECT scans?
There's 15,000 abstracts on SPECT on PubMed.gov today.
But again, we're talking about the need for the randomized controlled data to be able to take bias out of the equation. You said you have a more motivated patient population. These are all issues that can make actually SPECT not helpful for people. And perhaps a spending of money that is not valuable given how constricted our healthcare spending is already or needs to be.
So you're arguing we should just continue to fly blind?
No, I argue, but see, do you think I am advocating for flying blind? Can I tell you what I'm advocating for? Then you tell me if you agree with my notion. I think we should test SPECT to see if we can improve and no longer fly blind. And if it's not SPECT, perhaps it's something else. You don't think that's reasonable of me to say that?
No, I think more studies.
One study?
I think that would only help.
Yeah, I agree too. And I'm curious, why do you think they haven't been done?
I don't know. The first study that was presented in 1992 at the American Psychiatric Association is they took 100 bipolar teenagers. 50 of them were scanned on the day of admission. 50 of them were never scanned. They looked at the average length of stay. For the kids who were never scanned, it was 44 days. Now, this was when you could actually keep people in psychiatric hospitals. For the kids who were scanned, it was 15 days. It was an average cost savings of $15,000 per hospital stay. Is that the kind of study you're thinking about?
No, but it's getting there. That's a great preliminary piece of research that I think we can build upon, because I think we would agree that there's a hierarchy of evidence for recommendation, for deciding between causation and correlation. You agree with that?
Yeah.
So to me, unless we have that randomization where we take two groups, ideally match them as best as we can, randomize them so they don't know what they're getting, blind them, test the outcomes based on the treatments being more customizable and the SPECT category. And then if we see this drastic improvement, everyone changes their mind. AAN, APA is recommending it. We're all getting it done.
Yeah, see, that would be great if that happened.
You don't want to make a push for that on this podcast?
I'm not sure this podcast is going to get us to where we need to go.
Why not?
That would surprise me.
But this is so valuable. Like, I feel like SPEC can help so many people based on the way you're presenting it.
I think it can too.
But so if we present randomized controlled data to the AAN, APA, we publish it in the Lancet together, let's say, we can change the practice in the United States. Isn't that something you would want?
Absolutely.
So what's stopping us from doing it?
I'm all for it.
Okay. Well, at least you're for it. That's really exciting. Because when we think about people who are critics of SPEC, I want to prove them wrong, right? Because I want to help people and I'm on your side and I want to figure out how to get this done correctly. But if we're trying to do scientific research, it shouldn't be done in a way where Secretary Kennedy said, we're going to prove that this causes this. Scientific research starts with asking a hypothetical, asking a question, creating a hypothesis, disproving yourself, proving the null hypothesis, not just agreeing with yourself or seeking to agree with yourself. Do you agree with that?
And I was thinking,
you want to set out to disprove yourself if you're doing research, because ultimately, if you can't disprove yourself, that makes your information stronger. And look, there are some instances where correlation can be strong enough where you actually don't need a randomized controlled trial, because with
how do you do a randomized controlled trial on you have Alzheimer's or you don't? I mean, they have autopsy confirmed data that Alzheimer's disease, which has been described in the literature for 35 years. So you need better data than that to say SPECT can help in the diagnosis of Alzheimer's disease.
I need SPEC to differentiate itself from the standard of care as exists today for it to be found valuable and widespread recommendation.
Okay. And I would argue for...
Because SPECT is expensive, SPECT has radiation, it can fuel misdiagnosis. So I also don't want to overdo it with SPECT. So I'm trying to find the reasonable middle ground.
Okay.
Is that on? I don't. Correct me if please disagree with me.
Yeah. You're arguing for the status quo until someone can show you a randomized controlled trial for a specific diagnosis. Although I gave you the one with bipolar disorder. Yeah, I'm just thinking flying blind's not the answer.
I agree. I don't think we disagree.
And you didn't bring this up, and probably you don't know. The American Psychiatric Association last year named me a thought leader. But I'm not
attacking you here. This isn't, I'm not anti your work. I'm trying to figure out how to get your work to more people. We're on the same team, helping patients.
Yeah. And hopefully bringing psychiatry into the
I agree.
21st century rather than making diagnoses just based on symptom clusters.
I agree.
And I think...
I'm just trying to do it without doing it prematurely, because with any medical intervention, there could be drawbacks.
I don't think we did it prematurely.
But you don't have one randomized controlled trial.
Well, we're not thinking about it in exactly the same way. 1992, if I get a scan on the day of admission, it cuts hospital days 67%. That's pretty exciting. And what I saw as a clinician is it changed what I did 8 times out of 10. not only did it increase compliance and decrease stigma, it made me more effective because I had a roadmap.
I think that's great. But again, how do we get that out there? Because I'll give you an example. So for my patients who are over the age of 40, I can do the ASCVD risk score, which is their 10-year risk score of having a stroke or heart attack. Now I plug in some numbers into this calculator and I get a percentage. Based off this percentage, I can decide course of action for this patient. And the reason why I'm comfortable using the score calculator is because it's validated across diverse patient population, randomized controlled studies done on it, seeing what the actual outcomes are from doing this risk score calculator, as well as the interventions that follow. There's some people who make their own risk score calculators in the cardiovascular world, and they choose their own numbers to plug into their calculator. Here's why I don't agree with it, because it's not validated across a diverse group of patients. Do you see why I don't like their calculator as opposed to the 10-year ASCVD calculator? But some of them will come and show that their calculator helps 84% of their patients. Now, using their anecdote of helping their patients, should I then just throw away my other calculator and say, patients, I'm going to use this new calculator now because this person said this about their clinic? Or should there be a level of skepticism, like your father said, and said, BS, no, let's test it? Or should we just accept it?
Well, I think you should test it, which is why we do outcomes on all of our patients. Now, is that going to randomize? Is that going to go with your patients? No, but your patients will be better if you added imaging.
But you can't
are
say
we
that.
going to talk about the book at all? Or
Well, I mean, this is a premise of your book, no?
imaging is not the premise of my book.
Is not in your book?
It's in the book, but it's not
There's
the premise
images
of
of
the
SPECT
book.
in the book.
We're not going to talk about the book.
What do you mean? We talked about pain. We talked about the cycle of pain, how your brain has this blueprint that it starts cycling between that we're on board with. We talked about Dr. Sarno's work. Do you feel like I'm being unfair? If you think so, please tell me.
Yes.
How so?
Because you're like going on the same thing over and over again. It doesn't feel fun or fair, but I love talking about our work, and it's interesting to me. Often I've been criticized, and very few people go, so you've seen more scans than anyone in the history of the world. What have you learned? And as opposed to, well, you didn't do this and you didn't do that and you should have done this. And don't you think it'd be better if you did that? As opposed to, so what did you learn from nearly 300,000 scans?
Are you saying I said that?
No, that it just doesn't feel like it, right? I mean, I can only tell you my experience. It feels like.
But don't you think I should be a skeptic on behalf of my patients?
I think you should be curious.
So am.
Behalf of your patients, that if you could help them have a better brain, they would have a better life. And that things like Alzheimer's disease. So I wrote a book in 2005 called Preventing Alzheimer's Disease and got no end of grief. It's like that's
Why?
giving people false hope. And last year, The Lancet came out with an article that said 50% of Alzheimer's is preventable. And
what were the tips that you gave in that book?
so it was bright minds. You want to keep your brain healthy or rescue it, you have to prevent or treat these 11 risk factors. That if you're pre-diabetic, that's an emergency. Because diabetes, if you have diabetes, you have all 11 risk factors. Just that one.
Mm-hmm.
So it's going back to really creating this revolution in brain health, getting people to love and care for their brain. And if I was a family medicine doctor, I would be thinking is mental health is brain health.
Like the need for treating patients who have prediabetes. I frequently struggle actually in finding motivation from my patients when they do flag on their labs having a hemoglobin A1C in that level of saying, hey, this is when it's reversible. Because once technically, maybe there's some outliers. Once you become a diabetic, you're diabetic for life, at least in terms of your risk factors. Weight loss, extreme weight loss can seemingly control it because we've seen those who have bariatric surgery not need medications anymore, even though they were diagnosed with type 2 diabetes. But in the majority of cases, the time when it's reversible is the pre-diabetic stage. So I struggle in helping my patients get motivation there. So which of these 11 recommendations in the Alzheimer's book do you think that we're lacking in the primary care space so we can encourage doctors to do it?
I think it's that so much of these bad things that happen to your parents that we can prevent if we work together to be very serious about it. It's one of the beautiful parts about imaging. On my podcast, we had Julius Randle recently, 3-time NBA All-Star. He's depressed, smoking way too much pot, about to get divorced. And he saw a scan and he's like, oh no, I don't like that. Immediately stopped smoking pot. And a year later, his life's completely different because the images created an idea in his head that if he didn't do the right thing, it was going to get worse and he would be worse. And if he did the right thing, it could be better. One of the reasons I fell in love with imaging. It's creating the hope, and hope is tomorrow can be better and I have a role in it. It's creating that sense of agency in your patients. And if they don't ever get a scan, you could show them the images. If we don't do the right thing, your brain is headed this way. But if you do the right things, it can be better, which is why my first big book, Change Your Brain, Change Your Life, I think worked because it was a book of strategies and hope.
Yeah, because using that motivational tool as a behavior modification tool could be quite valuable. Like I actually am not against finding unique ways of trying to motivate my patients, because ultimately, if I had to say my biggest struggle outside of our healthcare system is finding motivation in my patients who are perhaps depressed or maybe don't even have a formal diagnosis, but have issues with life that are ongoing, that aren't easily resolvable, custody battles, divorces, etc. So my only concern with using the imaging as the compliance benefit is that if you were just using it in that way, I see the benefit. But then when you're criticizing the rest of the psychiatric community, it's almost impacting our ability to practice medicine because we're not doing the imaging. Do you see what I'm saying with that?
Yeah, but I can't not say what I believe the truth is, because then the field will never change.
But why
and
can't
if
you
the
just say
field
the
never
tool
changes,
is beneficial?
I'm sorry?
Why can't you just say, this is beneficial, this is how I motivate my patients? But when you say we're flying blind, you're creating this distinction for patients that are saying, we don't see Dr. Amen and we see Dr. Mike, we're going to get subpar blind care. Why would we ever do that? Why would anyone want to go see a doctor that's flying blind?
It's a good question.
But do you see how it sets up the dichotomy for patients where they have to make this terrible decision and they're already not in a good mental health space? So I'm curious, can we use it as a compliance booster, but not necessarily shame the rest of psychiatry, and instead...
So how do we move forward if we don't say that what we're doing is flawed?
We need to... Well, first of all, you could say what we're doing is flawed, but I think it's not fair to say you have the solution until we have the randomized controlled data.
Yeah.
You could say
And-
you're working
and I don't
towards
agree
that
because
solution.
I have outcomes on thousands of patients. I mean, I published the outcomes on the first 500. And this is what I believe, that if you don't look, you don't really know. And it's not based on 40 cases
Yeah, I'm not
that
saying it
we've
is.
seen. It's based.
You keep saying these criticisms and defending them that I'm not saying. I'm not saying that you have a limited number of cases. I'm not saying anything negative about you. I'm just saying that the randomized controlled data that I need for universal recommendation is missing. And I feel like that's important. I mean, the critics of SPECT say, depending if you have a cup of coffee, certain parts of the brain imaging will change. It's the same
No, they're
way
very
that,
consistent over time. There's a study from UCLA, Ishmael Mena, that over 3 weeks, there's less than 3% variability. Plus, in our clinic, we do two. We do one at rest, one when you concentrate. And so we have 100,000 rest concentration scans, and your pattern is going to be your pattern unless you get drunk. It does change during the time of your cycle, which is very interesting. If you never believed in PMS, the scans during different times of the cycle will convince you it can be a real thing. Yeah, no, they're very consistent over time.
well, given the fact that certain things interfere with them, couldn't that make it weaker? Like, for example, when I prescribe a patient to get a HIV screening test, right? I know the sensitivity and specificity is to a level that I'm comfortable giving this test to someone who has no symptoms. But in these scenarios, what is the sensitivity of a SPECT scan on the same person, weeks apart, across a diverse group of people? And does it hold up? We don't know that yet.
Well, Mena said it was less than 3%.
Well, in that study, but I'm saying the randomized controlled data is missing to be able to diversify it. Again, I'm not talking about the initial research being. I think the research that you're doing is so important because you need foundational research. The first doctor that said wash your hands in between the morgue and delivering patients was viewed as someone who's making stuff up and sees something on their
Yeah, he
hands.
died in poverty.
in the
Crazy.
in insane asylum or something.
Right.
So Ignace Semmelweis. But we need to be able to test whether or not these things are valuable. And I don't understand why you're not leading the charge for that as the number one proponent.
I've published more research than almost anybody on
But there's a
SPECT.
difference between
I
publishing
published
outcome
on-
data.
Outcomes, how it changes clinical practice. I published on ADD multiple times. We have a new study coming out on bipolar disorder. We've published on traumatic brain injury. I've published review papers. There's a lot of published research on it. We haven't done your study,
But you keep saying it's my study.
or the one
From
that
the
you
hierarchy of
keep talking
evidence.
about over and over again in the last hour or so.
Well, if you're trying to find out
But
something,
we've published a lot. I mean, it's very important for people to understand. In my book, The End of Mental Illness, there are 1,084 references. Because if I'm going to make this big idea, paradigm shift, stop calling it mental illness, start calling these things what they really are, their brain health issues, that I have to be able to back that up and talk about a lot of the research on SPECT for a wide variety of conditions. But even though I can tell you the pattern for OCD, I can tell you the pattern for autism, it doesn't say what your brain who has OCD looks like. And if you don't, because if all the patterns were 80% sensitive and specific, and we have ADHD data that's way higher than that, but not everybody has that pattern. That's why you look, not because SPECT can say, oh, you have this or that diagnosis. You and I can say you have this or that diagnosis. What you and I can never be able to do, is to go, this is your brain pattern and that's how I need to target the treatment to you,
Well,
not your cluster of symptoms.
We can change the threshold in the imaging to make it appear different.
So
Meaning
what does that mean?
basically
yes,
what I'm
I can
saying,
make your scan look terrible by changing the threshold.
Well, that's what I'm
but
saying.
why would I do that? I mean, I make how we
Well, when
render
we
the
make a
images.
threshold for what is prediabetes, we take a diverse set of people that is generalizable to the individual. And because we have this randomized controlled data, validated data, we can then say above 5.6, you're entering prediabetes. Above 6.5, you're getting diabetes. But with these thresholds, do we have validated thresholds to say this is where you should set your imaging parameters?
Mm-hmm.
We do.
Yeah,
And what,
with normal. We have normal, so average is 72%. So SPECT is a study of relative blood flow. What that means is we take the coldest spot in the brain, make that 0, the hottest spot in the brain, make that 100, and we scale everything between these two poles. And the average, most parts of the brain outside the cerebellum, is 72. And so 2 standard deviations is 6, 2 standard deviations, 84. So above 84%, we think that's increased activity in the brain. Below 60%, we actually use 55 for safety. It's 2 standard deviations or more below. Those are the thresholds. That's how we set it. Again, very consistent with the data from UCLA.
I have an idea for that randomized controlled study that you mentioned that I could design. What about taking people, randomizing them into 2 groups, scanning actually both groups with SPECT, but for one group, not using the SPECT data to guide treatment.
Yeah, that's what we talked about earlier.
So you're not treating off of that, but you're still randomized. Doctors still don't know. I mean, the patients still don't know which group they're in. And then going treatment-wise, and then seeing their outcomes from a clinical perspective, seeing how they're doing through patient surveys, and then also looking back at their spec, redoing their spec, and seeing if there's a change. Isn't that a great study that could truly perhaps prove that SPECT can be generalizable to the general public?
Yes, no, I think that's a great idea. And then we'd probably need 3 or 4 independent Aveman clinic sites to do that as well.
I think it's an important question to ask. If we do that randomized controlled study that we've just talked about, and it turns out that it's not useful, would you give it up?
Absolutely not.
Why?
Because how am I going to know if your symptoms are a result of your brain working too hard or not hard enough, if it's toxic or traumatic? So you're just asking me to give up, 35 years of experience showing how imaging changes what I do or guides what I do based on a study of 50 people.
Well,
now, I suspect the study will be...
People? Why'd you underpower my study so quickly?
well, there's 300 people, right?
What if it's
I'm not
10,000?
giving up imaging because
The
if you don't
evidence
look, you
disagrees?
don't know. I mean, there's this thing called face validity that it makes... I mean, there are just so many advantages to imaging that, probably if there were 50 studies done like that, 40 of them would come out positive and maybe 10 wouldn't. Why? Well, you've been around research long enough to go, whatever the person thinks is going to happen, they'll set it up to make it happen. That maybe you have way more confidence in imaging, in research than I do. But one statistician told me that 16 out of 17 statistics lie, depending on what people think. You saw Dr. McCary just come out recently with the hormone study, and he goes, when you actually read the study, they made that huge recommendation that kept HRT from women for 20 years, that it was actually based on flawed data. Well, so I'm not giving up the idea that imaging is useful. Can we use it better? Absolutely. And we're using AI tools in studying all of our patients' data, because they allow us to study anonymized data. So in my mind, no, I wouldn't give it up. But there's ways to use it better, I'm certain.
Mm-hmm. You said like 16 out of 17 research articles are flawed. Does that apply to your research?
No, 16 out of 17 statistics lie.
Oh.
So
is that true about your research as well?
No.
Why?
Because we want it to be reproducible.
But the rest of the scientific community doesn't? I'm just asking why your assumption is that this randomized controlled study would be flawed, but yours aren't.
You said I didn't have any randomized controlled trials.
I didn't say your randomized controlled trial. I said your trials. I just don't know why there's such a negative push to the scientific field. Like we're now discounting data because you're saying data is always flawed. But you use data.
So you don't believe that? Really? I mean, after all the time you've been a doctor.
Well, what's the question?
When you read
specific
the
question?
studies.
Please
Let's just take the
ask me a
one Dr. McCary, who's the commissioner of the FDA.
Women's Health Initiative.
Cited
Let's do it.
that when he actually went and looked at the data, it actually said the opposite of what the press release came out and said, which then hurt millions of women.
The medications that were used in that trial were appropriate for what that trial was trying to achieve. And what we were trying to extrapolate for it was not what the study was trying to achieve. In addition, the way that the study patient selected, which carries a tremendous impact on the study, they tried to pick people without menopausal symptoms, hot flashes, all of these things, because they were worried that if people saw their hot flashes improve, they would know and it would no longer be a blinded study. So there are criticisms of the research, and there's always criticisms of the research.
Always.
But my concern is that when you're ready to write off the research that disagrees with you, you're part of the problem that you just said, that if you're just seeking to agree with yourself, that how the scientific community says that you just said they do that. They try and get research that agrees with them. Don't you want to try and disprove your method in order to prove how strong it is?
So at this point in my career, no.
Why is that?
That if I looked at your scan, I feel really confident that it tells me how healthy your brain is, if it's overactive, if it's underactive, compared to not just our normal group, but our hundreds of thousands of scans. And for you to just sit here and go, but don't you want to prove yourself wrong? It's like, no.
That's the scientific method. When you fail to prove yourself wrong, that strengthens
yes,
your
early
argument.
on.
But we're pretty early
Is
on.
this
We don't have a
helpful or
randomized
not
controlled
helpful?
study.
Yeah. No, I
What
find
if
it
you
incredibly helpful.
What if you
but
scan my
I'm just
brain?
like, I'm just asking myself, what's the point?
Well,
Right? It just seems like we're arguing to argue as opposed to learn anything new.
If you scan my brain and it shows low brain activity, perhaps holes, sleepy frontal lobe, but I'm crushing it. I love life. I'm happy. I'm excelling at sports. Podcast is going well. What does that mean?
Well, it means you have low frontal lobe activity and you're compensating for it and you're not suffering. And so Alzheimer's disease actually starts in the brain 20 years before you have any symptoms. Frontal temporal lobe dementia starts in the brain way before you have symptoms. So what it means, in my mind, based on my experience, is your brain's vulnerable, and it's probably not good for you. So you may be crushing it, but are you going to be crushing it 20 years from now? Or would it be better for you to get it as healthy as it could be so you could continue to crush it and you end up not being a burden to your children?
That's a really good question. And I think the way we figure that out is by doing the research to figure out if that intervention will get me there.
So I think we should look at your brain. I have a clinic here in New York, and the radiation is about the same as a head CT, ordered millions of times every year in the United States.
There was a recent report that CTs are raising our risk of cancer by double digits. So got to be careful about that. But go ahead, sorry.
Ordered millions of times every year in the United States. I think it would be interesting. And then you could decide if it was valuable for you.
Yeah, my hesitation is, so why I tell patients who, residents rather, that want to reflexively check thyroid levels in my patients that are not having symptoms, like part of their screening, basically. A healthy person comes in and my resident automatically checks off checking thyroid. And I said, well, why? They said, well, I want to check and make sure it's optimized. So my question to them is, let's say a patient comes in and their T4 is marginally low. Are you going to treat that patient who's comfortable and then give them thyroid hormone, leading them to have palpitations and discomfort? So like every time I'm ordering a test, I'm trying to think, what if, how is this going to change my practice of care? And if you're saying that if I have these findings on the SPECT scan and I'm feeling great now, there's a chance I won't feel great later, I would want to know how sure of that you are based on randomized validated data. I think that's pretty reasonable to ask. No?
I think it's also reasonable to ask, is what's your experience? Is it as healthy as it could be? And I actually disagree with you. I think people should know their important numbers every year. Like you should know your BMI. You should know what your thyroid is doing. You should know your testosterone levels.
But there's such natural fluctuations of these numbers that are outside of your control that will lead you to premature, perhaps unnecessary treatment so many times. So many times.
So if you're hanging with a testosterone level of 250, which is not uncommon today,
okay,
you think,
what time of day did you test it?
Probably morning.
Because a lot of these clinics that don't do it in the morning in order to prescribe testosterone for their patients.
Which is bad. Because,
very bad.
Too high, your libido goes up and your empathy goes down and you get divorced.
Well, I think about also the medical problems that come along with that.
It's like, so I'm just, I often say, how do you know unless you look?
Well, thank you so much for your time. Thank you for your work. Everyone can check out the book. Pre-orders until December 9th.
December 9th.
And then that's when it publishes. Yeah. Congratulations on another. I know this is going to be a New York Times bestseller. So wishing you the best of luck for that. Thank you, doctor. Click here to see a list of 10 surprising causes of headaches. Your pillow could be. As always, stay happy and healthy.